And today's session is going through some investigations and ECG, which, as we have discussed earlier in the sessions, whether it could be part of the initial scenario itself, or will be part of investigation stations where you could have radiology or ABG, ECG investigations together, or created separately as a station. So we are supposed to have 2 clinical scenarios with 4 or 5 vignettes of each, which constitute to almost 80 marks. And we are supposed to have 6 stations of OSCE stations, and they amount to 120 marks. But what we realized in practice is that the marks in the clinical scenarios is a lot more than 80. And that there are always less than 6 stations in most of the exams. And because some of these stations are absorbed into the clinical scenarios and the marks are given like that. So except for ACLS airway, which are always going to be separate. So even though the investigations on ECGs are part of other stations or combined with others, the marks will still carry. And I want you guys to think about these in a way, because they will be counted somewhere, whether it is part of the clinical scenario or stations themselves, number one. So today we'll kickstart with some investigations on how to go about. I have Dr. Gopala Krishnan here with me, who's a consultant intensivist at Northside Manipal Hospital in Bangalore. So thank you, Gopala, for taking time and at a short notice doing these presentations. And Dr. Sunil Karan sends his apologies because he's got a STEP program, unfortunately clashing with this to do. And so anyway, those of you who are going to log into STEP program, you will see him there. That's that. And then following the investigations, we'll have ECGs. We'll have a freestyle session of ECGs. We have seen some yesterday. We'll see some more today, and then we'll just approach them together with a lot more involvement from you guys. Yeah. Without delay, request Dr. Gopala Krishnan to take over and continue the session.
Yeah. Thank you, Justin sir, and welcome to the session today. So without any further delay, we'll get into the some of the few investigations which we can discuss today. So right now, yeah. So we have a 58-year-old gentleman who's come to the ICU after the esophagectomy for CA esophagus, and he is day 4 post-surgery, and there is a difficulty to wean off this patient off the ventilator. So a few investigations which have been done for this patient, the pre-op and the day 4 investigations, so have been displayed, and gross abnormalities which can be picked up is one, hypokalemia, and then hypochloremia, bicarbonate is slightly elevated, hypophosphatemia, urea and creat are glossy normal, and hypomagnesemia. So what is the likely diagnosis, and what is the differential diagnosis? So yes, yeah. So it could be severe nasogastric loss, furosemide therapy, or refeeding syndrome. The answer is refeeding syndrome. So the biochemical picture is one of hypokalemic alkalosis. So in a patient on whom feeding has been initiated after a long time of starvation, they lead to hypokalemia, hypomagnesemia, and hypophosphatemic alkalosis. And profound hypophosphatemia is a cardinal feature of refeeding syndrome. So the other common cause is diuretic use and NG loss, but if it is due to a furosemide therapy, there will be azotemia. So the urea will slightly go up in these patients, and for the same reason, the large fluid loss are unlikely to be the cause unless there is a concurrent volume replacement therapy. Other causes of hypokalemic alkalosis is vomiting, villus adenoma of the rectum, steroid therapy, Cushing syndrome, Conn syndrome, and laxative abuse. Next question. We have a 36-year-old patient who is here with the following investigations and gross abnormalities. Yes, hyponatremia, potassium is slightly on the higher side, bicarbonate is low, calcium is on the lower side, phosphate is normal, albumin is less, urea is slightly elevated, creat is normal, AST ALT is almost normal, measured osmolality is 288, glucose is slightly high, and what we find is the lipase is markedly elevated. So this patient
somebody from the group will just say a quick likely cause, and then that will give them see how we're going to approach this problem.
So it is an acute pancreatitis case, sir.
Excellent. Yeah. So it is the triad of abdominal pain, hypocalcemia, hypoglycemia suggests diagnosis of acute pancreatitis. And in this patient, the urea is elevated because of intravascular volume depletion. And the cause of pancreatitis, if you see, the triglycerides are elevated. So the patient is having hyperlipidemia. So that causes pseudo hyponatremia. So hypertriglyceridemia can lead to pseudo hyponatremia. And the main management of pancreatitis is, of course, volume resuscitation and organ supports. But in patients with hypertriglyceridemia, plasma exchange can be used to decrease the triglyceride concentrations and helps in early control of hypertriglyceridemia. So next question, we have a 34-year lady who is shifted to the ICU from the labor ward. She's been diagnosed with preeclampsia and fetal distress, and she is having bradycardia. She is slow to wake up. She is having poor cough. She is having muscle weakness, hypotonia, hyporeflexia. So anybody in the group wants to take a guess what may be the cause of this features in this patient?
Magnesium toxicity.
Excellent. Yeah. So two possible diagnoses. Yeah, she's a post-op patient, so it could be because of incomplete neuromuscular blockade reversal, or it could be because of hypermagnesemia. So when we go back and look at the anion gap in this patient has anion gap of 3. It is less. So low anion gap or the reduced anion gap can be because of multiple etiologies. It could be because of hypoalbuminemia, hyperglobulinemia. Globulins are positively charged ions, so increased globulins can cause low anion gap. Lithium intoxication, bromide intoxication, hypercalcemia, and in this case, it is due to hypermagnesemia because she's been receiving magnesium as a treatment for preeclampsia, in which case we have to maintain levels between 3 to 6 millimoles per liter. And the above features are diagnostic of hypermagnesemia. So treatment includes stop magnesium, calcium administration. Calcium is an functional antagonist to magnesium, so we give IV calcium, diuretics, and if refractory, we go for dialysis. Coming to the next question, this is the venous sample of a patient. Gross picture showing hypokalemia, hypochloremia, bicarbonate is elevated, urea is elevated, creatinine is normal, calcium is low, and albumin is normal. So what could be the cause in this patient? Anybody wants to take a guess? Okay, no issue. So we are seeing a patient with hypocalcemia, hypochloremia, increased plasma bicarb. So hypomagnesemia will lead to hypokalemia and hypocalcemia because magnesium is a cofactor for the enzyme sodium potassium ATPase, and hypomagnesemia leads to potassium loss in the urine. So unless we replace the magnesium, the hypokalemia will not be restored. So hypocalcemia in the setting of magnesium deficiency is a combination of deficient parathormone secretion and inefficient parathormone action on the bone. So probable differential diagnosis includes inadequate intake due to malnutrition or alcoholism, excessive loss due to diuretic abuse, and diarrhea, drugs like amphotericin B and cisplatin, redistribution due to insulin and hungry bone syndrome. So we see this picture common in our intensive care units where hypokalemia because of a lot of diuretic use, possibly because of congestive cardiac failure, and these patients need magnesium replacement along with hypokalemia correction to improve the potassium. So coming to the next picture, we have this patient having low sodium, hyponatremia, hyperkalemia, sodium, potassium is elevated, chloride is low, bicarb is again low, glucose is less, urea is elevated, creat is almost normal, calcium is slightly elevated. So what
Anybody take a guess to describe the abnormalities, please, and what's the likely diagnosis?
Yeah,
If anybody,
what could be the diagnosis?
Adrenal insufficiency.
Excellent. Yeah. So these features are consistent with hypoadrenalism. So hyponatremia results because of hypocortisolism and increased levels of circulating ADH secondary to hypotension. Hyperkalemia is secondary to the reduced aldosterone levels. Hypoglycemia and hypercalcemia are also consistent with adrenal failure. Only 20% of patients with adrenal insufficiency develop hypercalcemia. So etiology is multifactorial: intravascular volume depletion, hemoconcentration of plasma proteins, and loss of anti-vitamin D effects of glucocorticoids. So a combination of hyponatremia and hyperkalemia can also be seen in renal failure, but the creatinine is normal in this patient. Besides, hypoglycemia is not common in renal failure. Spironolactone therapy can also lead to hyponatremia and hypokalemia. Sorry, hyperkalemia, because it's a potassium sparing diuretic. Coming to the next question, we have this patient with the following lab abnormalities. Gross picture.
somebody was gonna just to see how it goes. Anybody?
Yeah. Anybody wants to comment on the investigations?
Increased one creat ratio.
Excellent.
Excellent.
Yeah.
Dehydration, upper GI blood loss.
Excellent. Any other
High
differential
protein meal.
diagnosis?
High protein meal.
And one more. Steroids. So use of steroids. Yeah. So increased.
Excellent.
Yes.
Excellent. Oh, she's read the book, yeah.
Yeah. So
Yeah, actually.
Pancreat ratio is seen in dehydration. It can be due to high protein meal, GI bleed, and steroid therapy. This is the differential diagnosis of increased urea creatinine ratio. So this is the blood picture of a patient, and anybody wants to guess about the investigations and come to a diagnosis? Yeah, anybody can comment. Yeah. Go ahead. Ross thinks potassium is high.
Tumor lysis, sir.
Or yes, that's a possibility. Second thing,
HRS, sir.
HRS. Okay.
Yeah,
Okay.
that's good. That's good. That's good. Yeah.
Yes. So AST is elevated, ALT is normal. So possibly liver, both the enzymes gets high in liver.
That's
So two differential diagnosis, rhabdomyolysis or tumor lysis syndrome. This is common in this picture. We see a triad of hyperkalemia, hyperphosphatemia, and hypocalcemia, which suggests a cell breakdown seen in tumor lysis and rhabdomyolysis. So a low urea creatinine ratio is seen in rhabdomyolysis, excess production of creatinine, and in DKA. So we'll have to look at urine ketones. As we see, AST and LDH means the enzymes are coming from somewhere else, not the liver, possibly from muscle damage. Rhabdomyolysis is a common cause of AST going up and ALT being normal. Coming to the next question. We have a patient in the ICU who is admitted with gunshot injury with multiple bowel perforations. He's on TPN. He's receiving calories of around 3,000 kilocalories and proteins of 70 grams a day. This is the indirect calorimetry picture. The CO2 is 400 and VO2 is 300. We're finding it difficult to wean this patient off the ventilator. We see the CO2 is high.
To decrease the calorie requirement, sir. Because the CO2 is going up, so we have to decrease the total calorie requirement of the patient.
Exactly. This patient is being overfed. So that is the diagnosis. So we have something called as the Weir equation. We look at the energy expenditure using the VO2 and VCO2. So this patient indirect calorimetry shows that his requirement is approximately 1,600 kilocalories, but he's receiving almost a double of it. And excess calories is converted to fat, and in the process leads to increased carbon dioxide production. And we are having difficulty to wean this patient off the ventilator. Excellent. So this patient has undergone a therapeutic procedure in the ICU. So we see ionized calcium is less. The other parameters, protein C, antithrombin levels, proteins are all less. What could be the procedure the patient has undergone?
Plasmapheresis.
Excellent. I think, yeah. So this patient has undergone plasma exchange. So reduction in all the plasma protein concentrations and hypocalcemia due to chelation by the citrate, which is used as an anticoagulant in this patient. So liver disease can also produce a generalized reduction in the plasma protein concentration, but hypocalcemia is less likely in a patient with liver disease. So always look at differential diagnosis and try to reason out why that is not the reason in any given patient. So here we have a farmer who is presented with the following biochemical picture with pharyngeal ulceration, and he has a court hearing in the next day or so. So possibly some toxicology picture. So we have some biochemical abnormalities along with this picture. Anybody wants to take a guess what could be the reason why the patient is having the this picture, urea slightly high, and coags are normal. So this is possibly due to Paraquat consumption. So why we say that? Because farmers' occupation, so they have easy access to Paraquat. Pharyngeal ulceration is common in these patients, and they present with respiratory and renal dysfunction. And possible coat appearance could have precipitated the attempt to suicide. How do we diagnose? Clinical picture and sodium dithionate test of a urinary specimen. So the urine color changes to blue on addition of dithionite, confirms Paraquat exposure. So management, prevent systemic absorption, use Fuller's earth or activated charcoal, and treat as a patient with ARDS, but avoid high FiO2 exposure, as this patient have the tendency to develop free radicals and more pulmonary fibrosis. So just keep the FiO2 as low as possible in these patients. Coming to the next question, we have a 20-year-old patient who is come in an unconscious state with rapid deep breathing, CT brain normal, CSF is normal, pH is less, his PaO2 is low, he is hyperventilating, sodium is normal, potassium is low, glucose is high.
Honk, sir. Honk.
Yeah.
Honk.
What could be the diagnosis?
Honk, sir. Can be honk.
Honk. Okay. Okay. Any other differential diagnosis?
Ethylene glycol poisoning
Yes. Okay. Okay. Anything else?
or methanol poisoning.
Yes.
High anion gap.
Yeah.
With
So
osmolar gap.
yes, honk generally presents with very high sugars, typically more than 1,000. But this patient is also having what we call as osmolar gap. The serum osmolality is elevated, and the ionized calcium is mostly normal. So possible differential diagnosis of high anion gap metabolic acidosis. It could also be seen as we are saying the other differentials could be diabetic ketoacidosis or honk, but we have to look at the other clinical picture. So patient is developing fixed dilated pupils, subsequently suggesting methanol overdose. Yes, we will have to also look at exclude DKA by looking at measuring the urine ketones and plasma beta hydroxybutyrate. So classical manifestation of methanol toxicity occurs within 30 hours, approximately 40 minutes to 72 hours. Clinical picture is more of CNS, ocular, and GI symptoms. Visual symptoms and signs are related to concentration of formic acid, which is a metabolite of methanol. So we do a fundoscopy, we find disc hyperemia and papilledema. So how do we treat methanol intoxication? Anybody? So ethanol. So yes. So we give mainly supportive care and dialysis, and we try to correct the anion gap and metabolic acidosis, correct by giving bicarbonate. Yeah, we try to convert the methanol to ethanol. Yes.
Can anybody say what are the dialysable toxins? Dialysable toxins, anybody?
Lithium, sir.
We have to, yeah. Say the list. We have a mnemonic, isn't it? Correct. Anybody? dialyzable toxins?
Lithium, theophylline, then ethylene glycol, methanol, then barbiturates.
Yes, and valproate.
Yeah. So the
Ice
general,
tumble, yes, that's good.
Yes.
Excellent. That's ice tumble. Somebody's written. Yeah,
excellent.
very
So
good. Excellent. Yeah.
So any drug which has a very high volume of distribution is generally not dialyzable. So that's the general take-home message. So very high volume of distribution, they go on to third space. So it will be difficult to dialyze such drugs. So other drugs which are restricted to the what we call as the intravascular compartment are usually dialyzable. Yeah. So coming to the next question, we have a 50-year-old gentleman who's presented with pneumonia, and he is having a low saturation, and he becomes combative in the next few hours and starts having visual and auditory hallucination with mild hyperreflexia. So this is his blood picture. Any guesses on what could be the reason for combative behavior? Yeah, differential diagnosis.
Encephalopathy.
Yes, septic encephalopathy. Good. Anything else? So MCV is slightly high. So any picture, anything striking? So
Alcohol
Vitamin
withdrawal.
B12 deficiency.
yes, alcohol withdrawal, common. Yeah, acute alcohol withdrawal will manifest within 48 hours of stopping drinking. This patient, of course, is having a neutrophilia because of the pneumonia which he's got, but there is an anemia with macrocytosis, which is seen commonly in patients with alcoholism, and chronic ethanolics will have macrocytosis, which can revert back to normal in 2 to 4 months after abstinence. Other differentials include chronic liver disease, hypothyroidism, use of cytotoxic agents, and B12 folate deficiency. And of course, we need to replenish the folates and thiamine in these patients. So this patient is having combative behavior because of ethanol withdrawal. So what is the drug of choice for delirium tremens?
Benzodiazepines.
Excellent. Benzodiazepines. So benzodiazepines is the drug of choice. So next question. We have a 55-year-old gentleman. His plan for a surgery and his coagulations pre-operatively is as follows. So we find that APTT is slightly elevated, and they have done something called as mixing study, and in spite of that, the APTT is slightly elevated. So what could be the cause? So any guesses? Anybody? Okay, differential diagnosis for prolonged APTT.
Heparin.
Heparin, okay. Any other differential diagnosis? Prolonged isolated APTT interval.
Factor 8.
Extrinsic, what we call as the intrinsic pathway deficiency, factor 8, factor 9, and common pathway deficiency, hemophilia. Yeah. So this patient, if there was a factor 8 deficiency, and they have done this mixing study. They use a normal plasma and mix it with the patient's plasma. If there is a factor deficiency, the APTT comes to normal. So in spite of the mixing study, the patient's APTT is still elevated, means that there are some inhibitors for these factors. So it could be because of conditions like lupus anticoagulant or what we call as Apla syndrome. So this patient, there could be inhibitors of coagulation due to collagen vascular disease or cancer. So as I said, anti-cardiolipin antibodies and autoantibody screen will help us to diagnose these conditions. So though low molecular weight heparin or what we call as heparin can cause APTT prolongation, but when we mix it with normal plasma, it should be going back to normal. Yeah, so mainly we use DVT prophylaxis in the form of enoxaparin for these patients with antithrombotic prophylaxis, and we have to monitor the anti-10A levels to know the therapeutic levels in these patients. Coming to the next patient, we have a 48-year-old gentleman who's come with features of cough, breathlessness. He's been on diclofenac, methotrexate, prednisolone, and he's come with a background of rheumatoid arthritis. X-ray is showing bilateral infiltrates predominantly in the interstitium. SATs 73% with 6 liters oxygen. He's intubated in view of hypoxemia. They have done a BAL and gram stain and cultures are negative. So what could be the possible microorganism causing the patient's
ECP pneumonia.
ECP.
Excellent. So patient with immunocompromised state presenting with pneumonia, the first thing which we'll have to rule out is Pneumocystis pneumonia. How will we confirm the diagnosis? So there are special stains. We will look at BAL for GIMSA and methenamine silver stains. And we can also do a PCR for pneumocystis on BAL fluid. Treatment, first line, 4-trimoxazole, which is given in 3 to 4 divided doses. And if patient is also having HIV, we should add steroids. Second line treatment, pentamidine isothiionate. And we'll have to rule out patients, any patient with presenting with PCP, whether they have underlying HIV. As I said, they benefit with steroids, not the non-HIV patients. So we have a 55-year-old patient presenting with neck stiffness and drowsiness, and LP has been done. So this is the CSF picture. Anybody else wants to comment?
Meningitis.
Yeah. Yes, meningitis, yes, possibly bacterial meningitis, yes, good. What could be the possible etiology?
Streptococcus.
Streptococcus, okay, okay. Any other? But Streptococcus is gram-positive cocci, but
Gram-positive.
this patient is having a gram-positive bacilli. What is the differential diagnosis?
Listeria.
Listeria.
Excellent, excellent. So this patient is Listeria, monocytogenes is the causative organism. So clinical picture, neck stiffness, high incidence of seizures, movement disorders, fluctuating sensorium, blood cultures are more frequently positive than the CSF. So we have normal CSF glucose in many of these patients. What is the drug of choice?
Ampicillin.
Excellent. Dosage?
4 grams.
Yeah.
3 grams.
2
3
grams
grams.
IV, 4 tarli to 6 tarli. Yeah. So that is the drug of choice in these patients. Yeah. Excellent. So what is this picture? What investigation are we looking at? Thromboelastograph. Excellent. So this is a picture of thromboelastograph. So this is a point of care viscoelastic test which can measure the clotting and the clot formation of a patient's blood. We have various parameters, the R time, which generally indicates the onset of clot formation and depends on the clotting factors, the K time and alpha angle, which is dependent on the clot strength and the fibrinogen content of the patient's blood. The maximum amplitude depends on the platelets, and subsequently we have the A30 that depends on the clot lysis. Fibrinolysis is measured by this clot lysis. So a few important graphs in a patient with TEG. So prolonged R time, as I was discussing, is seen in patient with clotting factor deficiency, either because of hemophilia or dilutional coagulopathy. Patients with reduced MA or maximum amplitude is because of what we call as the platelet deficiency due to thrombocytopenia. And fibrinolysis, as I said, is seen in this sort of a picture because of possible patient has received a thrombolytic agent. This picture suggests a hypercoagulable state, and this is a sort of a picture in diffuse intravascular coagulation, where in stage 1 there will be a hypercoagulable state, but subsequently it will lead to fibrinolysis and a hypocoagulable state. So based on the TEG, we'll be able to diagnose what deficiency the patient has and will help us to supplement the appropriate blood products and medications. So if R and K is decreased and maximum amplitude is increased, it's a hypercoagulable state seen in patients with anticoagulants. Normal parameters, but patient is still bleeding. It could be because of a surgical ooze. We'll have to re-explore. The difference in R between TEG and TEG-H, wherein we give a heparin and repeat, it's more than 2 minutes. It's because of heparin. The treatment is protamine. Delta is less than 1.2, R is more than 9, and normal MA, it means it is hemodilution. If bleeding, re-explore or use desmopressin. Prolonged R and delta with normal MA means, as I said, clotting factor deficiency. We'll have to supplement with fresh frozen plasma. 1 unit for every 2.5 minute R prolongation. If the alpha angle is less than 45, fibrinogen is less, give cryoprecipitate. Maximum amplitude is less, it's because of low platelet function. Use desmopressin. If it is very less, we'll have to supplement with platelets. If the clot index is less than 1, it is primary fibrinolysis because of TPA. Use an antifibrinolytic agent. If the clot index is more than 3, it's because of DIC. Use an anticoagulant. So that is how we interpret TEG. It is shown to reduce the use of blood and blood products in patients with liver disease, post-transplant, post-cardiopulmonary bypass. And a very important point of care tests in these patients. So we come to the end of the investigations session. I request Dr. Mahesh to take over and probably discuss a few ECGs for a quick review. Anything?
Thank you, Gopal. Thanks a lot. By the time we set up with Mahesha's screen, so if all of you those who are listening, I have one session, one scenario. So patient is transferred to your emergency department, and you're asked to see these patients. The patient who is transferred from, let's say, Hassan, and he's admitted to the local hospital and transferred here because he's been having abdominal cramps, nausea, vomiting, and abnormal blood tests. And some of the blood tests that were brought out are important findings are platelets are 1.5 lakhs, PT of INR of 10, APTT of 120. And so what would be your differential diagnosis for this patient when you see him who is tachycardic, otherwise stable?
Any rupture, sir? Abdominal pain, as in DIC?
Paracetamol poisoning.
Yeah, excellent. So I guess at this point of time, the whole idea of asking questions is to see how we frame our answers. If you approach systematically, like most of these patients, whether most of the acute problems are infective or non-infective, easier way. So in infections, we could see this kind of coagulopathy. It's quite rare, but most of the time, the abnormality of these patients is toxicity, as you rightly said. Excellent. Somebody is messaged snake bite, so that's good. So what all toxins would cause isolated coagulopathy? So paracetamol, somebody said, which is good. So by the time we get to that term INR, they will usually be unconscious. But yeah, it is still a differential diagnosis. Snake bite is an excellent one. What else? Paracetamol, snake bite. Anything else? Rat poison, excellent. Rat poison, so that's good. Anything more?
Warfarin toxicity, DOAX.
Absolutely.
Overdose.
Yeah, no, excellent NOAX overdose. It is New York. So obviously, at the end of the day, whenever they ask you for these scenarios, the common scenarios are like they give you a DK, pancreatitis, or toxins, one of the toxins. So you usually have one or two differential diagnoses. Like let's say it's a DK, Honkan DK, and they would ask you to discuss a little bit about how to differentiate them. Or let's say you have meningitis, they would ask you a question about how to differentiate bacterial versus viral versus tuberculosis questions. So not too severe, but they generally would want you to go through it quite quickly, like how Gopala was going. So that was the speed at which your exam would run. So you're not going to be having too much time in between. So that's the reason why the pace of it is quite fast today, is because that's the speed at which you would score points. The more you answer, the more number of scenarios or questions would come for you. So hopefully you all got that rapid fire, and I'll see if we could go through a few ECGs with Mahesha. So I again invite Dr. Mahesha, whose unending support for this program can only be thanked effortlessly here. Please, Mahesha, start.
Thank you, sir. Hi, everyone. This will be, as sir said, it will be rapid fire only. Please read this. 48-year-old woman brought to triage by her daughter. She has been having nausea for past few hours, and past 60 minutes had a crushing central chest pressure. Past history includes hypertension and reflux. Heart rate of 66, blood pressure 170/60, saturation 99%. In exam, I think you will be given hardly 20 seconds to read ECG. And there may be additional questions in case of if there is some findings or if there is anything. Yeah? Anybody? Yeah, I mean, anybody wants to try?
Anterior wall changes.
Anterior wall. I mean, there is no typical changes if you see carefully. No clear-cut ST elevation. I mean, this is not significant as per the criteria. So this
Can be
is
GID,
nearly a
sir.
normal. Sorry, no,
It can be
nearly a
GID
normal
because
ECG.
patient is having a
Normal
reflex.
ECG.
Yeah, normally. So no, that's okay. No.
Yeah.
Tricky.
Yeah. So
Concave ST elevations in all the
So
Sorry.
maybe what we call as a marginally early repolarization. Maybe
yeah,
that's the
early
only
repolarization. Maybe
That's
yes,
probably the
something.
only finding that we could probably say.
Okay.
Other than that, I think sort of
Yeah.
it's okay.
So 34-year-old male presents to emergency with palpitations. Vitals checked at the triage include pulse more than 170, BP 112/76, saturation 98, GCS 15. Can anybody read this?
SVT, sir.
How do you manage?
Sir, we can give vagal maneuvers first. And patient is hemodynamically stable, so we can consider adenosine.
Okay.
6 mg.
What is the next line of management?
You can go with amiodarone, sir.
Okay. Excellent. This ECG from a 35-year-old male, type 1 diabetic. He presents with the generally feeling unwell with abdominal pain and dyspnea. Anybody wants to try?
We'll try describing the abnormalities. Maybe
Yeah.
that's a good start. Yeah, we'll just see what is not normal there. Okay.
There is a tall T waves in the anterior lobe, sir.
Excellent. Yeah. So I guess this is where it is when your eyes are reading an ECG rather than there is easy to look at an obvious diagnosis like an anterior wall MI. You're looking for it and then you see it and it's good. But if you don't, the next immediate thing we could do is that go through the algorithm. Like, is there a sinus, like rate, rhythm, axis, and changes in each wave. So that way, then you will come to it no longer than 20 seconds. So I guess some of you already have written some of the differential diagnosis. So I'll let Mahesha to confirm one or the other.
Yeah. I'm not able to see the chat box. Yeah, okay. Yeah, it is, I mean, likely to be hyperkalemia. Okay, tall T waves.
So what's the differential diagnosis of a tall symmetric T waves other than hyperkalemia?
Yes.
Early MI changes, sir.
Okay, what more? One more. I mean, ischemia is another, so symmetric TT waves. So that's something that we should think about. So other than just electrical abnormalities, ischemia is type 1 diabetic after all can have atherosclerotic disease.
So ECG of a 14-year-old female who presents following an episode of palpitations and associated dizziness. Anybody wants to identify what is happening? If you're not able to identify, just see what are the waves, what is happening to. Sorry? It's not wrong lead.
LVH is there, sir.
Yeah. Okay. So striking is striking findings now. So somebody said LVH. Yes, it is. Yeah.
QRS is very tall.
Okay.
It's a supraventricular tachycardia, so definitely it's a QRS complex is narrow.
Okay,
Like the
so
heart
somebody actually has written the written answer. Yeah, that's good.
Yeah.
Yeah. So it does look techy, isn't it? Quite fast. And whenever there is a fast, speed is normal. You want to look at it as an appropriate and inappropriate tachycardia. Inappropriate tachycardias most likely are arrhythmias. So when you look for arrhythmia, you want to look at and label it as an arrhythmia. So what could be the cause for this? Yeah, somebody has, I think a couple of people have written WPW, Mahesha.
I think PR interval is something which
Yeah.
you have to look at. Yeah. Okay. In treatment of choice. Sorry. Hello. How do you treat?
What are the things you won't give it?
Yeah. Okay.
Amide.
What are the things you want to give?
Avoid amide.
Anybody wants to try? Radio
Yeah,
frequency ablation.
Not sure about sort log.
Yeah.
Yeah,
Okay.
that's good.
Procainamide.
Procainamide.
Okay.
And
Flecainide,
Is it
procainamide.
Flecainide.
Yeah.
Yeah.
Correct.
We have flecainide. Flecainide is a bit difficult to get hold of now for us.
Flecainide is
Yeah.
the drug of choice.
Twice, yeah.
So these ECGs were taken from a 40-year-old male who presented with a 60-minute history of central chest pain. I'll put both the ECGs. Yeah. This is the first ECG. Yeah. I think it must have got interchanged. This is the first one. The other one is the second. Yeah. Anybody wants to read it?
Anterior one, sir, STEMI. Anterior.
Yeah. Yeah, I mean, if
lateral.
you is it anterior wall only or anterolateral?
Lateral.
Anterior and anterior.
Okay, there are changes in one AVL as well as V2 to V5. So more of extensive or anterolateral. Okay. So obviously you may get a question, how do you manage? I'm not going to the details of that. 72-year-old man with a history of hypertension and diabetes brought by ambulance within 3 hours of chest pain. On arrival, his pain has resolved following administration of fentanyl and uracil trinitrate. His pre-hospital ECG. What are you seeing here? You're not able to
Evolved
identify.
MI, sir. It's
Two
an evolved
waves in
MI.
V1, V2, V3, V4.
Evolved MI, sir. It is evolved MI.
Evolved anterior.
Because kidney fluids are there.
LBBB. Nuance
Yeah,
LBBB.
it is more of what we call as bundle branch block. So LBBB and poor R-wave progression. So is RBBB also requires equal attention like LBBB?
No, sir. No.
No, is it? No. Guideline has changed. So RBBB also requires equal attention like LBBB. A 20-year-old female who presented to emergency department following an episode of chest pain. At review, she was pain-free and all vital signs were normal. Anything abnormal?
RBBs.
Sorry.
RBBs.
RBBB, this is not the picture, right?
LBBB.
LBBB. With ST sagging in lead 2, lead 1, V5, V6.
Yeah.
Lateral volume. NSTEMI.
STEMI, no.
Antivolume.
No, this is more of Brugada syndrome ECG. Anyway, you can look into it. Okay. They may not ask you tough ones, but still. Okay. 65-year-old male who was brought to the emergency department following out of hospital cardiac arrest. ROSC was achieved pre-hospital following an episode of VT. On arrival, GCS3 intubated with the saturation of 98%, 75 systolic blood pressure. Anybody wants to read this?
Inferior volume.
Inferior posterior volume.
Changes.
Yeah.
Inferior posterior volume.
Why do you say it is posterior wall MI?
ST
There are
depression
depressions in
V1,
V1,
V2,
V2.
V2, V3 with an upright T waves.
Okay, okay, very good. But in lead 1, it looks like some lead, wrong connection of lead, but more of inferior wall MI with the posterior wall, correct. So 35-year-old presented to emergency with the palpitation, dyspnea, and lightheadedness. He has no past medical history. Vitals as shown, and this is the ECG.
Polymorphic VT.
Not complex tachycardia suggestive of polymorphic VT.
Sorry?
Polymorphic VT.
Not complex tachycardia suggestive of polymorphic VT.
Polymorphic VT. Is there anything to tell it is VT? Like what do you look for actually?
AV dissociations, fusion waves, and capture beats.
Excellent.
Okay, anything of that is there here? I think other than AV, which one? Sorry. Okay, AV dissociation is very prominent. Other things are not very prominent anyways. So how do you manage?
This is shock.
Is it? How much? What kind of shock? I think you need to be more clear. Why do you want to give DC cardioversion? Is it synchronized, asynchronized?
So yesterday we did ACLS, and I think some of the answers to a shock would always be synchronized or asynchronous, cardioversion, and the joules that you want to do. If you say all these things in the same breath, that would be a full answer. So otherwise, they would have to get all those things out of you. So you need to be very clear. So if you want to do unstable rhythms, whether it's ventricular or atrial, and based on that, you choose your rhythms, choose your joules.
So you want to manage with the medications, or you want to go for cardioversion? If cardioversion, what kind of cardioversion? And what is the joules used?
So synchronized cardioversion with the joules of about 120 joules.
Oh, very good. ECG from a 69-year-old gentleman who had a dual chamber pacemaker inserted earlier in the day. He complained to the ward staff of pain at the insertion site, and you have been asked to review him. Vitals were within normal. Yeah, I think ECG is here. So what you can see here,
All the beats are paced.
Yeah.
Atrioventricular pacing is happening, sir.
yeah. And is it normal? Normal pacing, or is there any abnormality? It's normal pacing pattern only, no? Nothing else here. Okay, 84-year-old gentleman presents with the generalized weakness, nausea, several episodes of diarrhea and dizziness, past history of atrial fibrillation, diabetes and hypertension. He was on multiple medications as told below. Conscious, vague but oriented, and BP is 112 systolic. This is the ECG.
Junction rhythm, sir.
Anything?
Complete heart block.
Complete heart block.
Junction rhythms are possible.
Toxicity.
I guess it is right though. Whenever anybody sees that slowness, you always say complete heart block first, unless proven otherwise, it will be. But yeah, you have to make a case for it. So the minute you say complete heart block, you need a second differential to go with it. This is what I think Mahesha is looking for.
Yeah.
What are the abnormalities that we see on the ECG?
Digoxin-induced toxicity.
Okay. Yeah, complete heart block is a possibility. Is there anything else we are seeing?
Junction rhythm is possible.
I mean, what are these waves?
Flutter loop.
Sorry?
Waves.
U waves, metabolic.
Yeah, U waves. So hypokalemia also you need to consider. Yeah. So obviously this could be digoxin toxicity with complete heart block, but other things you need to identify whether there are U waves, because there is history of diarrhea and vomiting and diarrhea.
So if I may ask,
Yeah.
sorry, Mahesha. So somebody tell me all the features of hyperkalemia on ECG, please. Just randomly, shoot out all the findings that you see on hyperkalemic ECG.
Salt
Hyperactivity waves.
So
Yes,
hypo.
go ahead.
Medics URS.
Hyperactivity wave.
Okay. This is
So that's number one.
complex absent.
Excellent.
VTM.
As the severity of hyperkalemia starts increasing, we start. Yeah.
And
Excellent.
should we stop here, sir? I think step session has started.
Okay. We'll give it to the last one, whichever you put it on, and then
Okay.
we'll do it.
ECG from a 70-year-old gentleman who presented with chest pain and palpitation. BP of 85 by 64. And he's on some oxygen. Just a second. I think,
Monomorphic VT.
Monomorphic VT.
yeah. So again, please know the management of each of them. So, yeah, sudden onset of occipital headache. Sorry. Yeah, I mean symmetric T wave inversions. I mean commonly seen in case of subarachnoid hemorrhage. Yeah, or sometimes raised ICP. So just a second. It's also not very. Yeah, this may be one of the favorite exam ECGs. Yeah, it should not take much time for this. Dancing down the axis. So torsates. Causes you should know. And if somebody comes with cardiac arrest, what medications you will use, that also you should know. You are aware, right? Magnesium. Hypokalemia, hypomagnesemia, hypocalcemia.
Yeah. So immediately the answer should include most of these unstable patients, ACLS, in accordance with the ACLS principles. Yeah.
Exactly. Yeah. Anybody wants to identify this even without history?
Hypothermia.
Yeah, correct. Usually there will be associated bradycardia. Yeah, Osborne J waves. I think there are many more ECGs, sir. I think we can wind up.
I know that that's okay. I think the idea is to just prime for the exam. Like one is step one is a pattern recognition, what we call. So the minute you see an ECG, you know that it is an MI or not, or RBBB or not. And if it is not immediately striking, revert to systematic evaluation of the ECG to see weight, rhythm, sign, axis, and waves, and so see you can interpret it better. And usually that will generally get you through. And so that generally most of the MI exam things are arrhythmias, MI, and rarely electrolyte abnormalities. So DG toxicity,
someone can try this, sir, if they want.
Yeah.
Whenever ECG looks very much normal, look into few things. It can be a whatever sinus, brady, sinus tachy, all those things.
Yeah.
If not, if it looks very close to normal, look at QT interval.
Excellent. So a lot of people already messaged QT Mahesha. They are on the ball.
Yeah, they are ready for exam. Yes.
They are ready for exam.
Yeah. This one, somebody wants to read.
Yeah.
Inferior volume.
Okay. I mean, I'll give you history.
Elevation in AVR.
1 second. Okay. Now just see where are all ST elevations. It is there everywhere.
Pericarditis.
Yeah. So it is non-territorial, isn't it? So it could just be because of the sympathetic storm, which is sometimes can be demand related changes. But the other thing is like somebody has already messaged to pericarditis.
Pericarditis.
Yeah. So it's cross changes. So
this is, I think, yeah.
Low voltage complexes.
Pericardial effusion.
Yeah.
Pericardial effusion.
Yeah, that's good. So
Yeah.
I think scenario would
But,
be
hypothyroid.
Yeah.
Mixed edema coma. Hypothyroid.
Excellent. Yeah, that's good. Tamponade, mixed edema coma.
This we have seen already.
Yeah.
Yeah.
Dorsal secondary to ischemia.
Yeah.
So this is AF is one of the commonest in ECGs in the exam. So I've seen quite a lot of people. So they ask you how you manage AF. So please remember, sort of based on the ECG AF, if patient is stable, what you do. If your AF unstable, how would you proceed? So be ready with those answers for arrhythmias. If the patient is stable, if they give you a scenario or just an ECG. So if they give you just this ECG, mention that if the patient is stable or unstable. So if they're unstable, then you concurrently manage them along with monitoring the ABC. So the management would include so and so, the DC shock or medications. So you just have to make sure that you frame your answers in a way that gives you maximum returns for the shortest of the time. So that you have more ECGs or more investigations to see and make up your marks during that time. So probably we'll wind up with that, Mahesha.
Yeah, this is actually not very typical flutter. Okay, it is a combination of flutter and fibrillation. So cardiologists call it as flitter. That's okay. Anyway, not very important. Management options may not differ much.
Yeah.
Okay, sir.
Sure. Thank you very much. I sincerely thank Dr. Gopala and Dr. Mahesh again for taking time and going through scenarios. Like I said, these could be part of your clinical station itself or independent station. Please be crisp with your answers, particularly electric shocks. Whenever you're saying cardioversion, make sure that what type of cardioversion and then synchronization and the joules that you're going to give. And yeah. And we'll have the last of our sessions on Monday. So till then, happy weekend to you all. And if there are any queries on 10th, we will have last minute, for exam related last minute queries or anything. We'll have a discussion on that day. Monday session, I will let you know, guys, based on how things are, whether we're going to start a bit early or at 7. Apologies because of the jumbled, a lot of concurrent programs. So this is all based on 10th being some of the R&B candidate exams. So I'll probably message you a little bit later today or tomorrow morning. And thank you all for joining in. And then there is a YouTube link on the chat box, so you could use that for those who missed out some sessions. So those whichever have been recorded have been posted on YouTube. So you can use as a guide. Thank you all. And